Bismillahirrahmanirrahim. Dear PGs, Assalamu alaikum. This is my third lecture in a row on dermatopathology. And this time I have brought a new concept for you to easily diagnose benign and malignant skin tumors in accordance to their place of location. I hope this kind of classification will help you in not missing to diagnose these specific tumors when you are examining a skin biopsy on a microscope or on a projection slide. First of all, let's grasp that what are the different histological types of benign and malignant tumors of the skin. And these skin tumors are usually divided into 6 groups. The tumors that arise from surface epithelium. There is large number of lesions, both benign and malignant, that originate from surface epithelium. Among the benign lesions, most common are actinic keratosis and seborrheic keratosis. And among the malignant conditions, most common are basal cell carcinoma and squamous cell carcinoma. Then the second type of skin lesions which we encounter normally are melanocytic tumors. These can be benign melanocytic nevi. The most commonly, the tumor which you will encounter in your exam is an intradermal nevus. There can be a compound nevus or a junctional nevus, and rarely you may encounter a melanoma. Then the third group of skin tumors which we commonly come across are the connective tissue tumors. These tumors either originate from a fibrous tissue, mainly the collagen, smooth muscles, or nerves. And the tumors originating from blood vessel endothelium also comes under this connective tissue tumors. Then the fourth category is the adnexal tumors. Adnexal tumors are those tumors that arise from a hair follicle or from a sweat gland or from a sebaceous gland. Fifth variety of tumors which we come across in dermatology are the lymphoproliferative tumors. These tumors include the mainly cutaneous T-cell lymphomas or B-cell lymphomas, then several different kind of histocytosis and mastocytosis. And last of the all are the metastatic tumors. That is those tumors which have a primary site somewhere else and only reach the skin as a manifestation of metastasis. In this tumor, main category is Paget's disease and also includes some other secondaries from different other part of the body. So this is the main histological types of tumor which we come across in dermatology. But in this lecture, I will be stressing on the diagnosis of skin tumors in accordance to their location. So starting from top to bottom, the first layer of the skin is the epidermis. So we will first discuss those skin tumors that arise in and from the epidermis. The first and foremost are the tumors of surface epithelium. Obviously, these tumors, they arise from either keratinocytes or from the pluripotent basal cells. Lymphoproliferative tumors. The most common is cutaneous T-cell lymphoma, which is most commonly seen in epidermis because of the phenomena of epidermotropism. Then melanocytic tumors, although the melanocytic tumors originate from the basal layer, but in the radial growth phase, these tumors, these cells, they are seen within the epidermis. And really, the few of the adnexal tumors, primarily those tumors which originate from the acrosyringium, that is the secretory portion of the acrine duct, they may be seen within the, within the epidermis. Then among the metastatic tumor, only the Paget's cells or the Paget disease is seen infiltrating the epidermis. So it can be summarized again. The tumor of surface epithelium, which we usually encounter in epidermis, are seborrheic keratosis, actinic keratosis, clear cell acanthoma, and in situ squamous cell carcinoma or Bowen's disease. Then we can see the radial phase of superficial spreading melanoma infiltrating the epidermis. Then few of the adnexal tumors can be seen like hydroacanthoma and poroma. Mycosis fungoides is seen in the epidermis as the phenomena of epidermotropism, having abnormal kind of lymphocytes infiltrating the epidermis, and the metastatic Paget's disease. So the first of the tumor that I will discuss in those which are originating in and from the epidermis is the seborrheic keratosis. You see, the seborrheic keratosis will appear as a polypoid growth with multiple nests and cords of basaloid cells with keratin pearl formation. So this kind of keratin pearl formation is seen in mainly three important tumors of the skin. In addition to seborrheic keratosis, there is squamous cell carcinoma and trichoepithelioma. Clear cell acanthoma also originates and is seen within the epidermis. This kind of tumor appear as the clear cells and psoriasiform hyperplasia. The clear cells, they have very sharp boundary from the normal looking keratinocytes. Actinic keratosis. Actinic keratosis have different histological presentations that include alternating columns of hyper and parakeratosis. Then underlying the parakeratotic column, there will be mild to moderate or severe degree of epidermal dysplasia. And in mild epidermal dysplasia, only the dysplasia is limited to the basal layer. In moderate, it spreads up to the mid of the epidermis, while in bovinoid actinic keratosis, there is full thickness dysplasia. This is a proliferating actinic keratosis. This is this will not be called as a Bowen's disease, neither will be called as squamous cell carcinoma, but there is mild to moderate degree of dysplasia which is seen in the basal layer, mainly involving the retinae. Bowen's disease is characterized by full thickness atypia with lots of mitotic figures, and Bowen's disease is characterized by the presence of pleomorphic cells, but these pleomorphic cells will be retaining their desmosomal connections with other keratinocytes. So these are several atypical cells. This is a big mitosis, and this is a cell with a large atypical nucleus. But you can see that even in the presence of such a marked degree of atypia, this cell is maintaining the desmosomal connection with the surrounding keratinocytes. Extramammary Paget's disease. Extramammary Paget's disease will look like there will be number of atypical cells with a clear halo that will be either present singly or in groups within involving the epidermis. So the group of atypical cells are called as the Pagetoid spread or the Paget cells. These Paget cells, they originate from intraductal tumor of the breast, and they are not keratinocytes. Hence, these cells are only infiltrating the epidermis as a metastasis, and these atypical cells will not be maintaining any desmosomal connections with the surrounding keratinocytes. And since these are not maintaining a desmosomal connections, there will be a halo surrounding these cells. So the presence of halo, grouping of the atypical cells together in nests, and the lack of desmosomal communication would help in differentiating Paget's disease from the Bowman's disease. This is mycosis fungoides or cutaneous T-cell lymphoma. You can see that there are large number of lymphocytes that are infiltrating the epidermis. This phenomena of lymphocytes going into the epidermis is called as the epidermotropism. And another characteristic of this phenomena is that these lymphocytes, they have a halo around them, just like the Paget cell, and these lymphocytes, they have abnormal shaped nuclei. If there is epidermotropism but with normal looking nuclei, then it cannot be called as mycosis fungoides. So to call as mycosis fungoides, the requirement is the presence of epidermotropism with lymphocytes surrounded by a clear halo, and lymphocyte nuclei should be of abnormal sizes and shapes, showing pleomorphism. These lymphocytes are arranged in form of groups, and this grouping of atypical lymphocytes in cases of cutaneous T-cell lymphoma is called as the Poirier microabscesses. So these Poirier microabscesses will also be seen within the epidermis. The atypical lymphocytes will have a halo surrounding them and will not be connected with the other keratinocytes by their desmosomal junctions. Then another skin tumor which originates from the acrosyringeum portion of the acrine gland is hydroacanthoma simplex. Hydroacanthoma simplex is the intraepidermal type of poroma, intraepidermal variant of poroma. The cells in this tumor are similar to poroma cells, which are called as the mini squames. These mini squames are similar to keratinocytes, but they are of smaller size and are maintaining the desmosomal junctions with each other. And these mini squames are seen clearly separated from the normal looking keratinocytes. So hydroacanthoma simplex is also seen within the epidermis. The acrine poroma, it is different from hydroacanthoma simplex is that it originates from the epidermis, but these strands of poroma cells are seen infiltrating into the dermis. So the tumor will be called as acrine poroma when the connection of these poroma cells with the epidermis is maintained, and these cells are going in communication with the epidermal cells into the dermis. While in hydroacanthoma simplex, the cells are only limited to epidermis. Tricholemoma is another tumor originating from hair follicle epithelium, and this trichoepithelioma is again seen within the epidermis only. The trichoepithelioma will give a crater-like appearance, as we also seen in keratoacanthoma. There is a crater-like appearance, but the cells of the epidermis, they have a clear cell morphology. So it is different from clear cell acanthoma in that in clear cell acanthoma, there is no crater formation. And it is different from keratoacanthoma that in keratoacanthoma, the cells are not clear cells. So these two features, that is the presence of a crater and cells underlying the crater are clear cells. This is a hallmark of tricholemomas. Then another tumor which can be seen within the epidermis is a radial growth phase of superficial spreading melanoma. Superficial spreading melanoma will give a pagetoid look, that these abnormal melanocytes will not be maintaining desmosomal connections and will be seen in groups or in singly or in the epidermis. But once we see this kind of appearance, there is also the junctional activity, that is the presence of abnormal melanocytes at the reti ridges, at the dermoepidermal junctions. So presence of these abnormal looking cells, melanocytes at the junction, along with the pagetoid spread in the epidermis, differentiates the pagetoid spread or radial spread of superficial spreading melanoma from Paget's disease. If the confusion persists, then we can go for immunohistochemistry to differentiate superficial spreading melanoma from Paget's disease. So this ends all the different kind of skin tumors that arise and are limited only to the epidermis. Now we will discuss those skin tumors that arise in and from the basal layer of the epidermis. So there are only two kinds of tumors that arise from the basal layer of epidermis. That is, the first is the melanocytic tumor. Since the melanocytes are present only at the basal layer, that's why all the melanocytic tumors, they originate from the basal layer of the epidermis. And then the tumor of surface epithelium, primarily the basal cell carcinoma. So these are the two tumors which originate from the basal layer, that is benign or malignant melanocytic lesions, or basal cell carcinoma, which is a tumor of surface epithelium. Freckle is cannot be called in a real term as a benign melanocytic tumor, but freckle is just an alteration in skin color on the face, and histologically freckle will not be different from a normal epidermis, but having increase in basal and suprabasal pigmentation. Otherwise, there will be no hyperplasia of the epidermis. In contrast to freckle, the lentigines are characterized by epidermal hyperplasia along with increased basal and suprabasal pigmentation. So the freckle has only increased basal and suprabasal pigmentation, while the lentigines will have epidermal hyperplasia as well. So this appearance is called as the dirty socks on a rope appearance. That is, if the socks are dirty and hang on a rope, then it will give the similar kind of appearance. Even lentigo will not be classified as a benign melanocytic tumor. However, the junctional nest can be called as a benign melanocytic tumor. The junctional nevus is characterized by nested proliferation of benign looking melanocytes at the dermoepidermal junction at the reti ridges. So these junctional levers, they shows the structural and architectural uniformity in between these nests. In lentigo maligna melanoma, there will be junctional activity, but here the junctional melanocytes will be having more of a spindle shaped structure. And in addition to these proliferating melanocytes, there will be a vertical growth phase in which these abnormal looking spindle shaped melanocytes are seen infiltrating within the upper and mid dermis. Superficial spreading melanoma also originates from the basal layer, and here the nests are showing structural as well as architectural atypia. And these nests, they are not uniform as we see in junctional levers. And these cells, they show gross atypia with mitosis. So superficial spreading melanoma is different from lentigo maligna melanoma in that the nest in lentigo maligna melanoma will be having the spindled morphology, and while the nest in superficial spreading melanoma will have epithelioid morphology, like epithelial cells. But these are not having any desmosomal connections with the keratinocytes. So these two slides, they are in a comparison between a benign looking junctional nevus and a malignant melanoma. Here you can see this is a very uniform nest of benign melanocytes retaining a good architecture. While on the right side, this is superficial spreading melanoma, where these melanocytes, they are of different sizes and shape, and there is no uniformity in architecture of these nests, these malignant nests. Basal cell carcinoma originates from the pluripotent epidermal germ cells in the basal layer. And these cells, the basal cell cells, they originate from the basal layer, and this origin from the basal layer is one of the typical feature in diagnosis of basal cell carcinoma, because somewhere in the skin biopsy, this origin can be demonstrated. The superficial spreading basal cell carcinoma is there are only the nest of abnormal nest of basaloid cells will be seen attached to the basal layers, and these cells can be differentiated from the normal looking keratinocytes, and the tumor is limited only superficially. However, even if the tumor is present superficially, it is retaining the usual features of a basal cell carcinoma, that is the presence of peripheral palisading and the retraction artifact. Retraction artifact means that the tumor contracts because these cells from which make up the BCC or basal cell carcinoma, they don't have any desmosomal connection. So once these nests are formed, they jumble up, as a result of which they lose the space between the stroma, and they contract, and the open space between these malignant cells and the stroma is called as the retraction artifact. So the third portion of the skin where we are going to discuss the particular type of tumors is the upper dermis. And usually the tumors in the upper dermis originate from the epidermis. These include, again, the tumor of surface epithelium, both basal cell carcinoma as well as squamous cell carcinoma. They are seen in the upper dermis, and melanocytic tumors. I have already discussed the two types of malignant tumors, that is the lentigo maligna and superficial spreading melanoma. So the upper dermis or papillary dermis or an upper reticular dermis is involved mainly by the tumors that originate from the surface epithelium, that is squamous cell carcinoma or basal cell carcinoma, or benign and malignant melanocytic lesions. This is a nodular variety of basal cell carcinoma. You can see the nest of basaloid cells showing peripheral palisading, retraction artifact, and cyst-like structures, and are also maintaining some communication with the superficial epidermis. This is a well-differentiated squamous cell carcinoma. These are the nests of squamoid cells, which are showing architectural and structural atypia, but retaining desmosomal junctions, will be seen infiltrating the upper or lower dermis, and these nests are seen separated from the overlying epidermis. And there will be a lot of keratinization because it's a surface tumor, so the keratinization is must. So if this keratinization is lost, then this tumor is called as the poorly differentiated or moderately differentiated squamous cell carcinoma. So this is a poorly differentiated SCC where you can see the abnormal nests, squamoid nest, but no keratinization. This is a poorly differentiated SCC. You can see the structural atypia, lots of atypical cells, and lots of mitosis within these. But even the most of the atypical cells, they are maintaining the desmosomal connections with the surrounding keratinocytes. Compound nevus. Compound nevus is a variety of benign melanocytic nevus in which we encounter the junctional activity as well as the intradermal nest of benign melanocytes. So compound nevus is a combination of junctional nevus and intradermal nevus. Spitz nevus. Spitz nevus is a benign nevus which many a time is confused with melanoma, but it is different clinically that these Spitz nevus are seen in young individuals while melanomas are seen in middle-aged or older individuals. Spitz nevus originates like the melanomas from the basal layer of epidermis, and then it infiltrates the dermis and have a typical wedge-like morphology. So starting from the epidermis and down to the dermis, the Spitz nevus retains the architectural uniformity in all the horizontal planes. Superficial spreading melanoma, when it enters the vertical or invasive growth phase, then this tumor will be characterized by abnormal looking melanocytes that will be seen in a form of junctional nests, along with nests of abnormal cells are seen in upper and mid dermis. In lentigo maligna melanoma, the similar nests of melanocytes are seen within the upper dermis, but these nests will be spindly in shape. They have spindled, they will be having spindled or tapering nuclei and lots of mitosis. So now the fourth region where you can find the different type of skin tumors is the main dermis or the main reticular dermis. So in this reticular dermis, we can see the melanocytic tumors like we have already mentioned, both superficial spreading and lentigo maligna melanoma. Then the main tumors which are seen in the dermis are the adnexal tumors because the hair follicles, the sweat coils, and the sebaceous glands are present within the dermis. And we see connective tissue tumors because the dermis is comprising of the collagen and fibroblast, and there are nerve bundles and blood vessels also in the dermis, along with erector pili muscles and the muscles surrounding the blood vessels. So all these connective tissue elements are also present in the dermis. So all the tumors that originate from the connective tissue will be seen within the dermis. Then lymphoproliferative tumors, which include the Langerhans cell histiocytosis and non-Langerhans cell histiocytosis, the mastocytosis, and the B-cell lymphomas will be seen within the dermis. And last but not the least, different kind of cysts will be seen within the dermis. So what do we expect? What different kind of tumors we expect in the dermis? They can be benign or malignant melanocytic lesions. They can be B-cell lymphomas, Hodgkin's lymphomas, histiocytosis, and mastocytosis. There can be fibroblast tumors, smooth muscle tumor, nerve and blood vessel tumors, also from the dermis. Then we can see the follicular, eccrine, and sebaceous tumors within the dermis and different kind of cysts. So all these kind of tumors will be present within the dermis. So among the melanocytic tumors, the benign one is the intradermal nevus, a very common tumor which is seen in the examinations as well. So this tumor comprises of benign looking nests of melanocytes within the dermis. There is a Gren zone and there is no junctional activity. If there is a junctional activity as well, then it will not be called as an intradermal nevus, it will be called as a compound nevus. So for intradermal nevus, there should be no junctional activity, will be a Gren zone, and then nest of benign looking melanocytes. The superficial nest of melanocytes will be having pigmentation, while the deeper nests are mostly not having any pigmentation. If we go down below, these cells, melanocytes will acquire spindled morphology, and this phenomena of conversion of round or epithelioid cells superficially to spindle shaped cells deep into the dermis is called as the maturation. So we can also see these blue nevus within the dermis, and these melanocytes, they are the interdermal melanocytes, which are of ribbon or elliptical shape. So this is a very pigmented tumor, and clinically it also gave an appearance of a blue color, benign looking lesion. Nodular melanoma are those melanoma which either arise, reach the skin as a metastatic phenomena, or arises from the epidermis, but with time, the epidermal connection or the junctional activity has ended, and only the intradermal portion of the melanoma stays. So this is a nodular melanoma which is seen only in the dermis with no connection with the epidermis. Trichoepithelioma is one of the most common hair follicle origin tumor. Trichoepithelioma appear as the basaloid nests which show peripheral palisading just like BCC, but it is different from BCC histologically. Number one, by not having any connection with the epidermis. Number two, by not having a retraction artifact, and number three, by having keratin pearls formation. Here you can see a trichoepithelioma, which looks like BCC, but because of the keratinization, it is called as trichoepithelioma rather than basal cell carcinoma. Trichoblastoma is another tumor originating from the hair follicle. Here there are basaloid nests within the dermis, not having any connection with the epidermis, but will not be having the keratinization as we see in trichoepithelioma. Another hair follicle tumor, which is called as trichofolliculoma, this is characterized by a large follicle, and in this large follicle, there are a number of other hair follicles are communicating or are opening into this large follicle. So this is called as the trichofolliculoma. Another hair follicle tumor originating from the medullary portion of the hair follicles, and this is characterized by two kind of cells, that is the ghost cells, which are the cells that have lost their nuclei, and the basaloid cells, which are surrounding or are at the periphery of these nests. So the pilometricoma is a common tumor of the face and can occur in other part of the body and is seen in young individuals. I've described poroma in the portion of epidermal tumor. Poroma is characterized by its origin from the acrosyringium in the epidermis, and from there the nests are seen going deep into the dermis. So the poroma is characterized by the cuboidal looking compact cells which are maintaining the desmosomal communication with each other and are seen well differentiated from the normal looking keratinocytes. This is another common acrine tumor that is called as syringoma. And syringoma is characterized by small nests of acrine epithelium, and many of these nests, they demonstrate the ductal formation, and some of them give a tadpole-like appearance, seen mainly in the upper dermis. Cylindroma. Cylindroma is a tumor originating from acrine epithelium. The cells, these nests, they are so compact that they give a jigsaw puzzle appearance, and there are two kind of cells in cylindromas. The peripheral cells will be darkly staining, while the cells which are present in the center of the nest, they are more eosinophilic. Acrine spiroadenoma. It is one of the painful tumors of the skin, originate from the acrine epithelium. There is a well-defined capsule, and again, there are two kind of cells, the basaloid cells and the cells with eosinophilic cytoplasm. Acrine hydradenoma or clear cell hydradenoma. Clear cell hydradenoma is a tumor originating from the acrine epithelium. It is an intraepidermal kind of tumor and is characterized by two type of population, that is the one with clear cytoplasm and other with eosinophilic cytoplasm. And in addition to that, there are several places where the duct-like structures are seen, and hence it is differentiated from other basaloid or squamoid tumors. Sebeciomas. There are different kind of sebaceous tumors which we see in the dermis, starting from senile sebaceous hyperplasia, in which only there is an hyperplasia of sebaceous glands, and then sebaceous adenoma, in which we see lots of sebaceous glands with a rim of basaloid cell. Then sebecioma, where the sebaceous component is less, while the basaloid component is more, and like we see here, there is a lot of basaloid component and less sebaceous component. And then sebaceous carcinoma, where there will be a total loss of architecture and loss of architecture of these sebaceous glands. Then after completing these adnexal tumors, we come to those tumors which originate from the connective tissue. And there are two important tumors that originate from the fibroblast are dermatofibrosarcoma protuberans and dermatofibroma. Dermatofibrosarcoma protuberans is characterized by a fibroblastic proliferating tumor having the spindle-shaped nuclei, which is seen starting just below the epidermis and involving almost whole of the dermis. And these cells, they will be running in fascicles in different direction, giving the storiform or rush mat appearance. This is a storiform of different fascicles running in different direction. In contrast, dermatofibroma is a well-localized tumor, and the epidermis overlying the dermatofibroma will be hyperplastic, while the epidermis overlying DFSP will not be hyperplastic, rather thinned out. And there is a small normal portion of a Gren zone or a normal upper dermis, after which the dermatofibroma starts. And dermatofibroma is also different from dermatofibrosarcoma protuberans, that there is an abundance of histocytes within the tumor, which is not seen in dermatofibroma. In dermatofibroma, only fibroblasts are seen, but in dermatofibroma, in dermatofibrosarcoma protuberans, only the fibroblasts are seen, but in dermatofibroma, both the fibroblasts and the histocytes are seen, and it is also called as benign fibrous histocytoma. Leiomyoma. Leiomyoma either originates from the smooth muscles of erector pili muscle or smooth muscles from the blood vessels. So it will be either a pilar leiomyoma or vascular leiomyoma. So in both the two cases, these cells will be having a cigar-shaped or blunt edge nuclei. These are the cigar-shaped nuclei. You can see the blunt nuclei. They are not having tapering or pointed ends. This is a neuroma, which is originating from a nerve fiber, and the nerve fiber is characterized by having a rather loose stroma, and the nuclei of the nerve nuclei will be spindly but having a wavy or comma shapes. So this is a neurofibroma where the tumor is rather loosely placed in comparison with DFSP, dermatofibroma, and leiomyoma. But the nuclei, they are either wavy or they are having a comma shape appearance. Now we have come to the tumors which are originating from the blood vessels. So there are various different kind of blood vessel tumor, but if we consider it which tumors are important exam, then one of this is pyogenic granuloma, which is characterized by nests of benign looking small capillaries. Then hemangioma, where is large dilated vascular channels which contain blood would be seen. But in addition to these, you can see various other blood vascular tumor like Kaposi sarcoma or angiosarcomas having origin from the blood vessels. Another tumor which is commonly asked in exam is a glomus tumor. Glomus tumor is characterized by several intercommunicating vascular channels with the endothelial lining and RBC surrounded by cuboidal cells, which are actually the glomus cells. Then the lymphoproliferative tumor that only involves the dermis is cutaneous B-cell lymphoma. So there is no epidermotropism in B-cell lymphomas. So in B-cell pseudolymphoma, which is seen as a result of insect bite reaction or other injuries or trauma, we see both B cells and T cells in single tumor. But in B-cell lymphomas, only B cells will be seen. Hodgkin lymphoma may involve the skin as a metastatic phenomena, and here you can see the Reed-Steinberg cells and other immunohistochemistry markers will also be positive for Hodgkin lymphoma. Various different kind of histocytosis, both Langerhans and non-Langerhans histocytosis, will be characterized by presence of abnormal looking histocytes occupying the dermis. So Langerhans cells and non-Langerhans cell histocytosis can be differentiated by the particular morphology of Langerhans cell nuclei, that is cleavage, and by the help of other immunohistochemistry stains. Urticaria pigmentosa is characterized by sheets of benign-looking mastocytes, mast cells, and these mast cells are characterized by a central nucleus and a peripheral cytoplasm giving fried egg appearance. We can see different kind of cysts in the dermis that include the pilar cyst, which is seen mainly in the scalp, or the epidermoid cyst in different part of the bodies, and the cyst wall will contain the same layers which we see in the epidermis. The epidermoid cyst will have this granular layer, but the granular layer will be absent in pilar cyst. So we have discussed the tumors in accordance to their specific location. So this algorithm will be helpful for you that you will not be able to miss any of the tumor if you see it in the exam or as a spotting or on projection slide. So just as a revision, I would like to revise that the tumors that involve primarily the epidermis, they include seborrheic keratosis, actinic keratosis, squamous cell carcinoma or carcinoma in situ, mycosis fungoides, and Paget's disease. Then those skin tumors which are primarily involving the basal layer include the benign and malignant melanocytic lesions and basal cell carcinoma. Then if the upper dermis is involved, then mostly the tumors which are involving the upper dermis are originating from the basal layer. So the tumors involving the upper dermis include the basal cell or squamous cell carcinomas and the benign and malignant looking melanocytes. Then the most of the skin tumors, excluding the surface tumors originating from the surface keratinocytes, originate within the dermis. And these tumors include the connective tissue tumors, which are the tumors that originating from the fibroblast and smooth muscles, nerve tissue, and blood vessels. And all the adnexal tumors will be seen within the dermis. And rarely you can encounter different kind of cysts within the dermis. So that comes to the end of this talk, and I hope this talk will help you in the preparation for your examination. And thank you and goodbye.